median value of soluble endoglins was 3.1 nanogram per milliliter in controls, 6.2 nanogram millimeter in cases with gestational hypertension, and 9 nanogram per milliliter in those who developed preeclampsia. The level of soluble endoglin was found to be elevated in gestational hypertension cases compared to controls, and it was even higher in cases of preeclampsia when compared to control with the statistical significance. In comparing plasma level of soluble endoglin in cases of preeclampsia and gestational hypertension, a high statistical significant difference was observed. This might give an idea about specificity of soluble endoglin in triggering preeclampsia. The current study clearly demonstrates the superior role of soluble endoglin in predicting preeclampsia at 15 to 18 weeks gestation. Pregnant females who have soluble endoglins more than 7 nanogram per milliliter are 119 times more likely to develop preeclampsia than those who have soluble endoglins less than 7 nanogram per milliliter in this cutoff. 94% of females prone to develop preeclampsia will be discovered. Combining this high sensitivity with this early timing of prediction, at least 2 to 5 weeks prior to preeclampsia onset, gives us a valuable tool for ensuring smooth pregnancy and delivery. An obstetrician suspecting the development of preeclampsia as early as 15 to 18 weeks could start prophylactic measures to ameliorate the condition before actual onset of manifestation, confirming the role of anti-angiogenic marker, justify therapy using an antagonist for the process of anti-angiogenesis. In conclusion, pregnant women who are at risk of developing preeclampsia can be offered assay of these markers as a screening method to point out those who are more likely to develop preeclampsia and warrant close observation and intervention. Thank you.
Thank you, Dr. Mariam, for your nice presentation. And now this is time for the video conference with Dr. Nicolaides about screening and prevention of preeclampsia.
Check the audio now on the whole. Can you hear me? Jose, can you hear me? No, we're just doing one thing about our audio. It's not fixed as yet. Just hold on 1 second. But you can hear me from my side, don't you? Jose, can you hear me? You lost my audio. Okay, just give us 1 second. They're just installing the driver software. Jose, can you hear me? Okay, yeah. Give us 1 second just to adjust our audio system here. Just 1 second, because obviously it's a whole. So just give us 1 second. Shema, can you hear me? I want you to talk, Shema, so we can actually check. Shema. Jose? Jose? Shema, if you can hear me, please, I want you to talk so I can test the sound. Shema, I need you to talk so I can test the sound, please. I need you to talk so I can test the sound. No, no, it's not working. Just give us 1 more second and I'll ask you for 1 more test. شغل الساوند اوت بتاع الجهاز. Hold on, it's working now. Shama, can you read it? Can you talk now so I can test the sound? No, hold on 1 second. Jose, can you test now?
Yes, 1, 2, 3.
Yes,
One,
we can hear you very well now. Let just tune the voice. So talk again, please.
1, 2, 3. Hello, good morning.
Okay.
Yeah.
Can you read
Hello?
the title of the lecture? Read the title of the lecture.
Yes, prediction and prevention of preeclampsia.
Okay, we're fine.
That-
We're fine. We're fine. We're ready to
Yes,
start.
fine, perfect. Just
Yeah.
let us know when you're ready.
Okay, can you read it 1 more time, please?
Yes, prediction and prevention of preeclampsia.
We're fine. We're fine. Okay,
Okay.
We're ready to start when Prof is ready.
So when you want, we can start. Let me
Yes,
know.
please. We're ready to
Yeah.
start. We're ready to start when you are.
Okay. Yes. Yes.
Hello. Good morning, Professor.
Ahmed, hi, how are you?
Good morning. On behalf of my co-chairpersons, Professor Hanish Hatta and Professor Magdi Ibrahim, they're sending their regards, and all of our attendees here. And thank you for your continuous support to our institution. And we're ready to start. Thank you very much.
Thank you, Ahmed, and I'm grateful to you for organizing this. It's a way of communicating with our friends in Egypt. I will discuss the prediction and prevention of preeclampsia. But before I introduce the topic of prediction, I want to take us back to what has happened in relation to screening for Down syndrome. In that aspect, we had a background, maternal age-related risk. The older the woman is, the greater is the chance that the baby has Downs. And that was the method of screening in the 1970s. Subsequently, can you hear me? Subsequently, Bayes' theorem was used to combine the information from the prior risk with the results of biophysical and biochemical tests. Essentially, for each woman, you take the maternal age-related risk and you multiply it by the likelihood ratio arising from the measurement of nuchal translucency. The greater the nuchal translucency, the greater is the likelihood ratio, the higher is the number with which you multiply the background risk to get the posterior risk. At the same then, we measure free beta HCG and HbA, and the higher the beta HCG and the lower the HbA, the greater is the likelihood ratio with which we multiply each other to arrive at the posterior risk. And this approach of starting with the prior risk and combining that with the results of biophysical and biochemical tests in the case of Downs, improved the detection from 30 to 90%. Now, if we then go to preeclampsia and we try to apply the same logic, we have a series of potential problems. First of all, in the case of Downs, the prior risk, the starting risk, is based on maternal age. Preeclampsia, there are many factors in the mother's history that affect the risk for preeclampsia, and therefore maternal age is replaced by other factors, and I will explain how we take these other factors into account in calculating the prior risk. In the case of Downs, the disease is very well defined. There are 3 rather than 2 chromosomes number 21 in the baby's blood or in the baby. But what is the definition of preeclampsia? This is a heterogeneous condition of different degrees of severity in relation to blood pressure and proteinuria and hematological changes, occurring at different stages in pregnancy. A Downs baby born at 24 weeks is exactly the same as a Downs baby born at 42 weeks. But this is completely different, the case of preeclampsia. Preeclampsia at 24 weeks can lead to maternal death, and for sure it will lead to fetal death, but preeclampsia at 42 weeks can easily be cured by delivery. So the definition of preeclampsia is more difficult than the definition of Downs. What are the biophysical and the biochemical tests? In the case of Downs, it is nuchal translucency, HCG, PABA, and more recently, placental growth factor. And these are converted into multiples of the median after correction for those maternal characteristics that affect these measurements. What are the biomarkers in the case of preeclampsia? Well, we have the uterine artery pulsatility index, we have the mean arterial pressure in terms of the biophysical tests, and for the biochemical tests we have PABA, PLGF, and FLIT. Again, the logic must apply that each one of these measurements must be corrected for the variables that affect the concentrations of the measurements, and they must be expressed as MOMs, multiples of the median. In the case of Downs, and I will be discussing that later on, a new approach is emerging where we do first-line screening for everybody based on the combined test, and then on the basis of the results of that, we define various risk categories, some of which require an invasive test, others require further assessment, perhaps by cell-free DNA analysis of maternal blood, and a low-risk group that do not require any further management. Can we apply the same logic in the context of preeclampsia? So I will take each one of these questions and try to answer them in the context of preeclampsia. Let us therefore begin with the prior risk. How do we define what is the risk for each woman based on maternal characteristics and obstetric history? Various organizations, the American College of Obstetrics and Gynecology, the WHO, World Health Organization, the NICE guidelines in England, identify a series of factors, and they essentially divide them into two groups. The high-risk factors, that if you have one of these factors, you are classified as being at high risk. And these factors is, did you have preeclampsia in your previous pregnancy? Or do you suffer from chronic kidney disease, autoimmune disease such as systemic lupus erythematosus or antiphospholipid syndrome? Do you have type 1 or type 2 diabetes? Do you suffer from chronic hypertension? And then we have the moderate risk factors, and you are screened positive if you have 2 or more of these factors. First pregnancy, age more than 40, an interval between your pregnancies of more than 10 years, a body mass index of 35 kilograms per square meter or more, and family history of preeclampsia. This approach to screening has never been validated, but we have recently examined 120,000 singleton pregnancies, and we try to examine There is a lot of talking from that side. I'm not sure. Can you hear me?
We can hear you very well, Prof. We can hear you very well, and the voice is very clear on our end.
So maybe they can turn off the microphone there because...
I will turn off the microphone. Thank you.
So if we try to examine the value of this method, then we can find that of screening is a detection of about 35% at the false positive rate of 11%. So the traditional screening can identify about 40% of the women that develop preeclampsia, and they will first be classifying 11% of the total population as being screened positive. Now, let us now examine an alternative strategy. If we take the general population and we assume that all women, if you are pregnant for long enough, will develop preeclampsia. We have developed a mathematical model which shows that on average women will develop preeclampsia when they are 55 weeks pregnant. Now, what is the logic of this? survived long enough, we would all develop cancer of the prostate on average at 120 years of age. Of course, almost every